Hello, good morning. I'm Ashok Kurokode, consultant rhinologist and anterior skull-base surgeon from Winchester and University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to the second day of inaugural Winter Global Rhinology and Skull-Base Surgery Webathon. Global Rhinology Network is a non-profit organization with a mission to foster surgical education in rhinology and skull-base surgery. We have successfully hosted annual multi-center live surgical webcast, the LIONESS, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We had hugely informative and engaging 15 sessions on endoscopic sinus surgery presented by eminent rhinologists and skull-base surgeons on day one. We'll be having similar sessions today focused on anterior skull-base surgery. This event is hosted at the Global Telemedicine Studio of Professor Wilco Grolman in Utrecht, the Netherlands. It is supported by Medtronic and Karl Storz. So, may I introduce today's first speaker, Dr. Luiz Alexandro. He is from Brazil, and he's the chairman of the neurosurgery department there. He has done a fellowship with Dr. Albert Rothon, so he doesn't need any more introduction about his anatomical expertise in endoscopic skull-base areas. So sorry, there was a bit of a delay in joining in, but can I invite you, Luiz, to start your talk? Thank you.
Right, thank you, Ashok. First of all, it's a great pleasure to be here, to be participating as a neurosurgeon in this forum where we have many ENTs, and I hope I can pass to you some of our knowledge that we have been developing in the last years. I may share my screen right here. There is a message here that says I can't share my screen. The host. No, now I think
now you can.
Okay. All right. So, can you see my screen?
Yes, we can. Thank you.
Yeah. All right, thank you. So we will be talking about the anterior skull-base anatomy, and especially what's meaningful as my point of view for the approach for the cellular regions, the cellular region and the cellular pathologies and related areas. This is our team. I have no conflicts of interest. And we start saying that there is each day more possibilities of access to this cranial skull base, and we have many approaches to perform, but it remains constant that we need to know even more and every time more anatomy of this region. 1 minute, please. So when I started doing this, I went to Dr. Rothon's lab, and these were the guys I've been working with there. I had the pleasure, and always with the mentoring of Dr. Rothon, which is a very important person in my formation. And also, I'd like to thank in my development for Dr. Velotini, which is who's a neurosurgeon in Brazil, and Dr. Augustin, DNT from Brazil, that has gave me the opportunity to participate as staff in the Barretos CD course for the last 6 or 7 years. We may start saying that we need to have a 3D comprehension of this area, and we like to center everything as a initial point for comprehension in the sphenoid sinus. Sphenoid sinus is this area that all is related to. So we have the orbit related to it, we have the nasal cavity, we have the maxillary cavity, we have the anterior cranial fossa. So everything is related to this sphenoid sinus. And if we understand the relations in this sphenoid sinus, we have halfway done to comprehend this area. We could make a whole session talking about the osteology of the anterior cranial base, because we have many details in this area. But I may say that we just, if you have to focus on one bone, of course, it would be the sphenoid bone. As neurosurgeons, we are much more enthusiastic and used to look for the lesser ring and the bigger ring, the greater ring. But when we are talking about endonasal and anterior cranial approaches, we are talking about the body of the sphenoid bone. And we will see that because here are the structures that we will be working with and dealing with and avoiding. So this is the center of this our particular world. So as we say, we have the central part of the sphenoid bone, and of course inside here the body we have the sphenoid sinus, but we also may pay attention to this area, which is the pterygopalatine process and the basis of the pterygopalatine area, where we have these two openings. One is below and medial, which is the opening of the Vidian canal, and the other one is lateral and superior, which is the opening of the rotundum foramen, which will give passage to the second division, V2, second division of trigeminal nerve. As we look to the sphenoid bone, we used to start as neurosurgeons that we may say that opening the rostrum of the sphenoid like this. But as we developed and we made the partnership, the very important partnership with ENTs, we have seen that we have many other possibilities of drilling bone and getting access to other areas. And of course, as more bone we drill, more vascular and neural structures will be in our field of operation. So we need to know all of them. The anterior fossa, as we see mostly going from intracranially, we will be dealing basically just going from subfrontal and then accessing all this area. And of course, if we drill all the roof of the middle cranial fossa, or the not the roof, but the floor of the anterior cranial fossa, we will be exposing the cellar area. And what's the same thing we are doing from an inside, from an endonasal point of view, but the anatomy is still the same, just with another syncope. So understanding the anterior cranial fossa looking from inside the brain, the skull is pretty simple, because we have three bones, which is the sphenoid bone, we have the frontal bone, and we have also the sphenoid bone composing all this area. And this is completely or mostly flat, or a little bit with some little accidents, as we see in the area of the cribriform area and crista galli, but mainly it is plain. And this is one way of seeing that. The other way of seeing this area is dividing it in a central portion and the lateral portion. The central portion being the cribriform area, the sphenoidal planum, the planum sphenoidale, or the tubercular area here. And laterally, we have also mainly the orbits, the relation with the orbit. And the same thing may be said as we look from downwards. We are looking here at axial cut from the head and looking from below to above. And here we see the roof of the sphenoid sinus, the roof of the maxillary sinus, and the same division we did before we can apply here, looking at the ethmoid, looking at the the frontal bone up there, and also the sphenoid bone down here. And also the same division as we said. So this is the most important thing, is to divide the structures in the midline and structures, as we said, the orbits, the relation to the orbit in the lateral portion. Of course, even if we come from inferior or from superior, I may say from intracranial, or if we come from the nose, we are facing every time anatomical details, vascular structures, bony details, and neural structures that may be comprehended in detail. When we go from the nose, from endoscopically from the nose, we have this, of course, the limitations of the orbits, because we can't go further from the orbit with the endoscope here and here. So this is our path. This is our route for approaching all the structures we have in this area. And that can be perfectly understood if we look from intracranially. We can see very well the limits, the medial limit of the orbit, and here all the nasal cavity exposed, and of course the ethmoid cells above it. So in the point of view of a neurosurgeon, I learned a lot with my partner, which is Dr. Gerson Mas, the ENT, and we get in the nasal cavity. And for me, and I believe for many people, the middle turbinate is one of the most important structures we have here. Why? Because if we get to in the head of the middle turbinate and we advance posteriorly, we'll get in this inferior and anterior part of the rostrum of the sphenoid bone. And if we open from here, we have no vascular and no neural structures. So we can start opening the sphenoid bone from this area to above, or going below, or going downwards here. And we can safely remove all this rostrum of the sphenoid. And here we can show again the middle and the inferior turbinate, the middle turbinate, and the nasal septum. And if we follow the middle turbinate, we get access to this lower portion of the rostrum of the sphenoid bone, and we can open it and get access to our main area, as we said, the sphenoid sinus. Another important detail about the middle turbinate is that if we remove the middle turbinate tail, the last third of the middle turbinate, as we can say, we will be exposing this area, this opening, which communicates laterally the sphenopalatine. Here you can see the sphenopalatine fossa with the nasal cavity, and passing here, which is the sphenopalatine artery, the last branches of the sphenopalatine artery, as we say, the most important one for these approaches, which is the nasal septal branch of this artery. So middle turbinate is very important for us as a landmark for navigating and understanding the anatomy of this region. Here in more detail, you can see we have opened this area. We have opened the sphenopalatine ostium, and here we can see the video nerve coming to the sphenopalatine ganglion. So look how important it is to understand and to comprehend the tail of the middle turbinates. And of course, we can see that pretty well in CT scans and understand the anatomy, all the Vidian canal here, the anterior, the carotid siphon, and here the pterygopalatine fossa, as we are going to talk about it a little bit later. The sphenoid sinus can be understood in three different ways: in the sagittal plane, in the axial plane, or in the coronal plane. And if we see it in the sagittal plane, it will be like a rectangular shape. But if we look at the axial plane or the coronal, it looks like a trapezium because it has a narrow posterior part here, which is limited laterally by the paraclival carotid artery in both sides, and expanded anteriorly by the lateral recess of the sphenoid sinus, which we'll be talking a little bit later. In the coronal, we can see the same thing, but the limitation laterally will not be the carotid, but the orbital medial wall in one side and the other side, and it goes here laterally to the same sphenoid lateral recess that we said before. Talk about the lateral recess. This area is located just lateral to the impression of the video nerve. You can see here the video nerve, and we can see lateral to it this expansion. The more aerated is our sphenoid bone, the larger will be our lateral recess. And the lateral recess, of course, is also an important anatomic landmark for some reasons, and we'll discuss it in a few moments. As we see here in the sagittal plane, we can see the lateral recess, which is delimited, limited medially by the video nerve that comes from the lacerum foramen to the pterygopalatine fossa, but it's limited also superiorly by this impression, which is the impression of V2 in the wall of the sphenoid sinus. So lateral to V2 and video nerve, we have the sphenoid lateral recess. Why is this important? Because we are going to see about the relation of the lateral recess and the cavernous sinus. Again, this specimen can show you that in one side, we didn't have proper aeration development of the sinus, so we don't have here a lateral recess, but we have it perfectly exposed here, and you see here the course of V2, the impression of V2, and going laterally to it, the sphenoid lateral recess. So this specimen is pretty beautiful to understand that, and here we have the channel for the video nerve. As we see specifically the sphenoid sinus, I like very much to understand it first in the sagittal plane. And we can see many structures here. The most reliable and most present one, of course, is the pituitary fossa, the wall, anterior wall and inferior wall of the pituitary fossa, the pituitary, the sellar fossa. And what we see here is many times when the tumor grows here, this area gets enlarged, and sometimes it occupies great part of our sphenoid sinus. But we can see also in this sagittal view the anterior band of the carotid siphon here, which is more or less seen as the sphenoid sinus of again is more or less aerated. So this is also important to see this structure. We have the lateral recess, as we said before, inferior to V2 and lateral to video nerve. So here is the lateral recess. The V2 impression and OPTIC-CAROTID recess can be seen here in lateral and superior to the carotid siphon, and medial and inferior to the optic canal, as we're gonna see better in the coronal plane. For seeing the sphenoid sinus in the coronal plane, what we need to do is most times in surgery, you have to remove the posterior cells of the ethmoid bone. So because the posterior cells of the ethmoid bone are part of the wall of the sphenoid sinus. So we have to remove the ethmoid posterior cells to get access to our sphenoid sinus. Now we have removed all the ethmoid, and we can see the first structure that we see when we get in the sphenoid sinus, which is the intersinusal septum or complete septum, and the partial septa that may go to one point of the carotid in the lateral or more medial way. So we can identify this. It's very important to understand clearly the position of this septus, this septum and the partial septa when we look in the CT scans. And that's why CT scan is so important. Even if we have a very good MRI, we must make a CT scan in our patients to understand particularly well this anatomy of the septa, because we may be distracted or be misorientated if we don't see exactly where our septa are sending us to. We can see also here the pituitary fossa located in the midline, and the clival recess. The more aerated, again, the more aerated the sinus, the bigger we'll see the impression of the clival recess. We can see pretty well here the optic-carotid recess located here, where, as I said, it is the optic-carotid recess has the carotid, medial and inferior to it, and we have also here the recess and lateral and superior running the optic canal in both sides. We can have a very well demarcated optic carotid recess or a flat area that we can't see it pretty well, but we may try to see it pretty well. The pterygopalatine fossa, which is even each time more important structure, because many access to expanded lesions, to expanded access to this region, will be doing it through the pterygopalatine fossa. And this fossa is a narrow space that comes from the infratemporal fossa to the nasal cavity, and it is positioned between the anterior wall of the sphenoid sinus and the posterior wall of the maxillary sinus. So it's a 2 to 3 millimeter space, sometimes 5 millimeter space, and for 1.5 centimeters, rough 1.5 centimeters from lateral to medium. As we see here, we can see clearly that for exposure of the pterygopalatine fossa, we must remove the superior part of the maxillary posterior wall. Here we have the pterygopalatine fossa, and here we have the basis of the pterygoid process, and so this area is not pterygopalatine fossa. This is the infratemporal fossa here. So there is a line here, and as you can see, the bone over there. If we look laterally, it's even more easy to understand where it's located. Here we are seeing the maxillary bone, and here the sphenoid bone. And this in white is the palatine bone. The palatine bone is the medial wall of the maxillary, the pterygopalatine fossa. So here is the sphenopalatine ostium that, as we said before, looking from medial to lateral. And also, if we see it in this more inferior part, we can see the lateral limits of the pterygopalatine fossa, and here the infratemporal fossa. So it's the pterygomaxillar incisure, and this is the lateral limit of our pterygopalatine fossa. One other thing that I like to comment here, which is very important, is the cavernous sinus. As neurosurgeons, we are very used to know the limits and the position of the cavernous sinus when we see it intracranially from lateral to medial. But the anatomy is the same. So here, this is the position of the carotid artery. Here is the third nerve, the Gasserian ganglion, V3, going to the foramen ovale, V2 going to the foramen rotundum, and V1 going to the superior orbitary fissure. And we know that as a definition, we can consider the V2 as the inferior limit of the cavernous sinus. And if we drill this area, remove the nerves, and if we remove the bone and drill here, what we see here is this sphenoidal mucosa. So the relations are always the same. So when we look medially, as we know, this is the impression of V2, remember? So here we have the carotid artery. Here is the impression of V2. Here we have the the V1 go into the superior arterial fissure, and V3. And as we know, this is the inferior limit of the cavernous sinus. What we can say is here is cavernous sinus. Why is that important? Because I know that if I drill the medial wall of the sphenoid side here, middle wall of the sphenoid sinus here, I get in the cavernous sinus. But if I drill the wall here where I have the lateral recess, I don't have anymore the cavernous sinus. I will be facing the dura of the middle fossa and exposing the most medial part of the temporal lobe. So we can go from here, and his area is very safe for drilling without entering the cavernous sinus. Here we can see V2 more clearly, and here is the limit of the cavernous sinus when we see it from inside to outside from endonasal aspect of approach. In the coronal plane, we have here the cavernous sinus. We have thinned the wall of the sphenoid sinus, and you can see pretty well the extensions of the cavernous sinus. As we may say, especially we must pay attention to the intercavernous sinus, inferior intercavernous sinus. Why? Because many times when we are opening our dura in this area, in the pituitary fossa, we may cut this cavernous sinus connection here, and we have some bleeding here. So we must be prepared to deal with. We don't have many image studies that can be reliable on saying if this sinus here is small or large. So we must be always prepared to deal with this bleeding. Many times just putting the head of the patient more higher, we can stop the bleeding from this intercavernous sinus here. Once we remove the cavernous sinus, we are seeing completely what we see from the carotid. We see about the carotid from inside. We are seeing here the vertical portion of the cavernous carotid. Then we have the posterior band and one horizontal segment coming from posterior to anterior. And then we have the anterior loop of the carotid siphon. We can see pretty well here the glands, the pituitary glands, the adenohypophysis and the neurohypophysis posterior there, and this trabecula, which are ligaments that sustain in position the pituitary gland. And sometimes we'll need to cut these ligaments to make a lateral entering between the carotid and the pituitary gland. If we see, this is a straight view, and if we look in the 30-degree view, we can see pretty well the Gesserian ganglion, V2, going from the ganglion to foramen rotundum here. We can see the video nerve going to the pterygopalatine fossa coming from the foramen lacerum. We can also see here the sympathetic pericarotid sympathetic plexus that will join the sixth nerve that is running lateral to this vertical portion of the carotid, as we will see in detail later. So if we look here, we know all the structures that we have in the medial wall of the sphenoid sinus or medial wall of the cavernous sinus. And this is what we said in the beginning, where we see the body of the sphenoid and the openings, or forming the opening of the Vidian canal here, which is this area, the opening of the foramen rotundum here, and this area of the superior orbitary fissure here. When we are in surgery, one other important detail about this anatomy is the intercarotid distance in the siphon area, because the carotid has always this lateral to medial orientation in this area. So we may and we need to know exactly what is the distance we have from one carotid to the other, because when we are doing our incision after removing the anterior wall of the pituitary fossa, we must know where the carotid exactly is here and exactly is here. Sometimes we can't see it pretty well, but if we see and if we measure the distance lateral to the right and lateral to the left from our intersinusal septum, we can measure if, for example, we have 5 millimeters to one side, we have 7 millimeters to the other side. So this is a very good orientation information for not making damage to the carotid artery. And one other important, very important structure, as we see here, is the relation of the optic carotid recess that we said from the nasal is very, very important landmark, because it shows us the carotid siphon and it shows us the optic canal. And this is why when we have here, what is missing here is the anterior clinoid. We have drilled the anterior clinoid, and what we are seeing here is the final part of the optic strut. The optic strut is a structure that that comes from the clinoid to the bone of the sphenoid bone, to the wall of the sphenoid bone. So what we see is that the optic carotid recess is nothing more than the optic strut. Here, if we see from intracranial, we see the optic strut, and if we see from endonasal, we are seeing the optic carotid recess. They are the same structure here. So as we enter the nasal cavity and we get to the rostrum of the sphenoid, we will always or almost always see this losangular shape, which is the insertion of the vomer in the rostrum of the sphenoid. And we can see the left and the right sphenoid ostium, which can be bigger or smaller, asymmetric in size and position, but always in the upper third of the rostrum of the sphenoid bone. Here again, we are just talking about the relation of the tail of the middle turbinate and the most inferior part of the rostrum of the sphenoid. So I can open from here upwards, or of course I can go from the ostium, the sphenoid ostium, and downwards. Many times we start drilling here and opening the sphenoid sinus upwards. In one side, seeing the wall of the sphenoid sinus, and here we remove the wall of the sphenoid sinus and we start to see the structures, as we said. The first one to be identified is the sellar area, or the pituitary fossa impression. And also we have lateral here, the optic carotid recess, which shows us that the carotid artery is running here, medial and inferior to it. So here is the carotid artery, and superior and lateral to it is running the optic canal. So this is a very important landmark to be observed. We also can see here, many times we see people calling this area of planum sphenoidale, but planum sphenoidale comes from these medial limits of the optic nerves anteriorly, because all this area is the tuberculum sellar area. So this is not planum sphenoidale. Planum sphenoidale comes from here to anterior. If we see in the 0 degrees or 30 degrees lens, we can see that we have a bit more exposure of this area of the planum sphenoidale area, but the anatomy is basically the same. And here is even more easy to see the anterior band of the carotid siphon, medial and inferior to the optic carotid recess. In the 30 degrees, looking lateral, the optic carotid recess, and very well exposed the anterior loop of the carotid siphon. The V2, the impression of V2 here. So this is the optic, the lateral recess of the sphenoid sinus here, down and lateral to the impression of V2. As we drill that area, we see the same anatomy as we said before, here in the 0 degree lens and here in the 30 degree lens, just showing the Gesserian ganglion V2. So I know that here, if I drill here, I get in the middle fossa. If I drill here, I get in the cavernous sinus, as we said before. We are showing here what we said before about the intercavernous sinus. Here we have the bone, and now in the left side we have removed the bone. But actually, what we must see when we look at this is this: we must have an X-ray view seeing the gland and this intimal relation of the gland with the horizontal part of the carotid siphon. Again, the same structures we have said before, but here the prevalent sinus is the superior intercavernous, and we have a very little or nothing inferior intercavernous sinus. So this is, in this example, would be much easier to open the dura of this patient. And again, showing us the relation, the intimal relation of the carotid area with the lateral wall of the pituitary gland here, and also removing the area of the tuberculum sella and planum sphenoidale. We are showing now the optic nerve in the left, the chiasm, and the optic nerve in the right, the gyrus rectus from the frontal lobe, and also the interhemispheric fissure here with the anterior cerebral artery. The same thing we said before in the midline, we can say laterally, just as we commented before. This is a V2 impression. This is V2 here. So here we have bone, and now we are seeing it as a naked medial wall of the cavernous sinus. Special attention, and we could talk a lot about the suprasellar region, but special attention must be paid attention for this small artery, which is the superior hypophyseal artery, not only because it irrigates the pituitary stalk, and if we damage these arteries, we may have some endocrinological problems, but this artery also gives branches to a bigger part of the anterior chiasm. So if we damage these arteries, we may have some partial blindness or partial visual field damage for our patients. One other structure that I want to just remember you that we don't talk a lot is not only the optic nerve, the chiasm, and this optic nerve in this side, but this artery, which is the ophthalmic artery that runs inferior and medial most times to the optic nerve. As we see here, this is the anterior loop of the carotid siphon. This is the optic nerve, and the ophthalmic artery usually is medial and inferior to the nerve. So when we go from the sphenoid sinus here and we open the roof of the sphenoid sinus, we must pay attention for not damaging this artery, because we may cause blindness in our patients. And one last detail about this area is the course, the running of the sixth nerve that comes from the dura in the posterior fossa. We removed here the Dorellus canal in the apex of the temporal bone, and then we see clearly that it runs lateral to this vertical segment of the cavernous carotid artery. Runs lateral, and this point anterior to the carotid, it receives branches from the pericarotid sympathetic plexus going to the superior orbitary fissure. Here we are exposing the apex, the petrous apex there, and now we removed more of the apex, and we can see the complex of the 7th and 8th nerve, the 6th nerve here, and the carotid is displaced more anterior, just to show how can we get access from the nose or from the contralateral maxillary sinus to this area of the petrous apex. I have here one case to sample this information we said. You see a not big but not small pituitary tumor here. The carotids are partially involved with the tumor, and one thing may be said that many times that we see a suspected cavernous sinus invasion in most of this, or most of parts of the time, we don't have an invasion, just we have a displacement of the medial wall of the carotid sinus, and the tumor is really contained in the pituitary fossa and not really extending for the cavernous sinus. There is a paper, I really don't remember now, but I can send to you later, where they observed the extension of the tumors to the carotid side, to the cavernous sinus, and they said that they observed that more than 40% of times where we believe there is invasion of the cavernous sinus, we don't have it really. We didn't have a lateral displacement of the medial wall. So we here, I'm sorry. So we are here showing the middle turbinate. We follow the middle turbinate. Most times, as you know, as ENTs, we don't need to remove the middle turbinate. We can put it laterally. We can displace it laterally, and we are showing here the superior turbinate and the rostrum of the sphenoid, and making the same work in the other side, putting lateral, displacing laterally the middle turbinate and getting to the rostrum, and there the sphenoid ostium. Now we are facing already the sphenoid sinus, and that shape that I showed you that has a losango or diamond shape here, as we see the insertion of the vomer in the rostrum of the sphenoid sinus. Then we are inside the sphenoid sinus, and we see here, for example, in this side, in this example, in this surgery, you don't have a very well presented midline intersinusal septum. We have just this partial septa here that we can see they are not in the midline. So we must know the anatomy of this sinus before entering surgery. I'm sorry, let's jump in here. And then we can expose more, and we are drilling the vomer here, the insertion of the vomer in the rostrum. And then we expand our opening laterally, removing with the ronger the lateral wall of the sphenoid. And then we can drill, and also with this ronger, we can open the pituitary fossa to its limits. We like to expose it pretty well to have a very wide exposure of the area, so we can open the dura and work in the tumor and remove it. This is another example showing the middle turbinate pointing as the rostrum of the sphenoid, and then we are making the nasoseptal flap, as you all know, and we learned a lot of it with our colleagues from ENT. As I may say, we never operate a single patient with pituitary lesions or lesions in this area without the participation of one ENT colleague, because we know that ENTs have much more experience in the nasal approach, especially in the nasal cavity, than we have as neurosurgeons. And we start, it looks like a very narrow space in the beginning, one ostium of the sphenoid, the other one, and they have the rostrum here, but this diamond shape here, that is the insertion of the vomer. And we can drill it, or we can remove it with a ronger, and we are going to remove it. And many people ask how much I need to drill from the rostrum of the sphenoid to get in there, to get in the cella. And we believe that there is no specific measure here. We must drill here enough to get access to the inferior wall of the pituitary fossa, as we may need to drill the inferior wall to have a clear access to the pituitary fossa. So that's what we do. Here, now we removed more, and now I can see my aspiration my section is down there. below the pituitary fossa. Here we are drilling a very thick sphenoid septum, intersinusal septum here. And as we drill, we have a more clear exposure of the pituitary fossa. Then we have the dura exposed, as we said, the tuberculous area, the planus sphenoidale area. Lateral, we have the OPTIC-CAROTID recess, and we make this rectangular shape opening of the dura, exposure of the tumor, and we try to dissect the tumor laterally to see its lateral limits. Sometimes it's possible, sometimes it's not possible to do that. But then we start aspirating the tumor. Some bleeding is usual, and we can again put we can elevate the dorsum of the patient, so we may have more control of this bleeding without the need of using hemostatic agents. So the work with the curettes, but not only blind curette work, but we can see what we are doing gently, and we start removing the remnants of tumor. As in the end, we can enter with the endoscope inside the pituitary fossa. We can see here the gland, and we don't see any more tumor, and we are looking with 30-degree lenses just to see if everything is okay, and then the closure with the nasoseptal flap. Thank you very much, Ashok, for the invitation once again, and I may answer the questions. I think we had 2 minutes left. Thank you.
Thank you very much. I'd like to launch a poll for 1 second before Ashok will continue, because we really need to get the poll in as well. It's important for us to have an impression of what everybody is, who everybody is, etc. I'm sorry for doing the poll. Please answer if you can, and we'll remove the poll in a couple of seconds.
Thank you, Luis. That was excellent presentation. I mean, there were lots of positive feedback, compliments on the chat groups. So there's a question from David Whitehead. What is your approach on about drilling on the optic canal in case of meningioma encasing it?
Right. This is a very how can I say, tricky discussion, because many people believe we can't do it from inside, from the nose, and I believe we must pay real attention for where the infiltration of tumor is in the optic canal. If we have it infiltrating inferior to the optic canal and medial to the optic canal, we may have a very good exposure coming from the nose, and we can drill it perfectly. Even more, not only we can drill the medial wall and the inferior wall of the optic canal, because we are seeing the optic-carotid recess. It's not difficult, it's easy to do it, and I see no big deal in drilling that. I don't know which is real, the doubt that I may answer, but I believe that this is the best indication for going from the nose to opening the medial wall of the optic canal. I'm sorry for the rusty English, because in these pandemic days we are traveling not too much. So,
well, that was excellent. Thank you. And there are some questions on the chat line. So if you're able to answer them,
sure, of course,
I can.
So
thank you.